Hello, welcome to the EUROGEN webinar series. Just before we start, I want to take a couple of minutes to explain a little bit about what EUROGEN is and does. So EUROGEN is one of 24 European reference networks created and funded by the European Commission since 2017. And we're currently a network of 56 hospitals in 20 member states. And our aim is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urogenital diseases and complex conditions who all need highly specialised surgery. So I hope you noticed the slides at the beginning. One of our activities is we offer virtual cross-border consultations using a secure IT platform provided by the European Commission to all the ERNs. So if you have a particularly tricky case, we would really strongly encourage you to get in touch with us, and our network of experts can provide some advice or guidance. And this service is absolutely free, so please don't hesitate to get in touch. So this webinar this evening, we're absolutely honoured to have 4 experts who are presenting this evening. So we have Professor Anne Ebert at the University of Ulm Medical Centre, Dr. Nina Younsi and Professor Raimund Stein, and they're both at the Centre for Pediatric, Adolescent and Reconstructive Urology, University Hospital Mannheim, and finally Bernhard, who's at the Department for Pediatric Urology at the Hospital of the Sisters Charity, Ordensklinikum in Linz. And the topic this evening is primary obstructive megaureters, where of course the timely diagnosis and management are absolutely crucial. So we're delighted that our experts will be sharing their experience on how best to treat these patients. And this webinar is supported by the ESPU, and live attendees are also eligible for CME accreditation. So advice will be given at the end on that. So do enjoy the webinar and feel free to ask questions. Thank you. I'll hand over now to Bernhard. Bernhard, you have the floor.
Right. Yes. So good evening also from my side. Sorry for the technical difficulties. It's my pleasure to have the first task of 4 speakers to report about diagnostics, what is really necessary in primary obstructive megaureters. You might ask yourself whether this is really important to ask the question. I think it is, because primary obstructive megaureters are very frequent and then most of them are benign, so we should really aim to do only what's really necessary. And having no conflict of interest, I think we could make this very short, because as soon as you know it's a primary obstructive megaureter, there is not much to do. So I would like to focus on what actually is a primary obstructive megaureter and how can we definitively diagnose it, and then what puts children with a POM at risk for renal functional deterioration and of problems now or later on. So the definition of a primary obstructive megaureter is any ureter with a retrovesical dilatation of more than 7 millimeters without reflux. It should not be secondary to any other condition, of course, not ectopic. And there the question is, can an upper pole megaureter be a primary obstructive megaureter? It actually can't, because it is ectopic by definition and it does not behave like a primary obstructive megaureter in his follow-up. It should be obstructive, and we will delve further into detail about what obstruction actually is later. And it can happen with or without upper tract dilatation. It's connected to a considerable risk of urinary tract infections during the first 1 or 2 years of life, and a relatively low risk of need for surgery, which of course is a very subjective endpoint. So why 7 millimeters? There are 3 publications that are very interesting to mention, and I think this is an important question, because that's the main criterion. In 1967, there is an autopsy study by Cousin, and he described the dimensions of a normal ureter starting at the 20th week of gestation with about 0.5 to 0.65 millimeters. And on that, Hellström in 1985 built up and looked at radiological data from 165 children, mainly intravenous pyelographies, and could in a way confirm the findings by Cousin. And this is why most people think, and it was adapted into literature, that 7 millimeters is the upper cutoff. Only recently, Sarah Holtzman showed that it really is important, because 7 millimeters is a significant cutoff, as you can see at the Kaplan-Meier plot on the right side, is a significant cutoff for a higher UTI risk in dilated ureters. So 7 millimeters is also relevant and not only historically to be understood historically. But how many ureters actually are primary obstructive ureters? So I've looked into our data and into megaureters diagnosed less than 1 year of age, so everything that is dilated more than 7 millimeters retrovesically in children less than 1 year of age. And of 168 such megaureters, only 63 were actual primary obstructive megaureters, because many were reflexive, some had urethral seals, quite some were ectopic, and 10 were secondary megaureters due to valve tumors or stones. So if you see a dilated ureter, the risk that it's, or the chance that it's a primary obstructive megaureter might be around 40%, and certainly not more. So the first diagnostic step, of course, is sonography. We can check the upper tract dilatation and its extent. We can see for the presence of stones. We can exclude most urethral seals. We can try to exclude an ectopic ureter, but that might be difficult with sonography alone, though I think it's possible in most of the cases. We can check for kidney dimensions and volume, but that does not really tell us anything definitive about the differential renal function or about an obstructive outflow with the risk of further loss of differential renal function. And we can see secondary signs for reflux, but we cannot really exclude it. So about reflux, does it matter at all? For the definition, it matters, of course. For the symptoms, it might, and for the progression, we actually really don't know if we look into literature. And then there is another problem, that VCUG, a normal radiologic VCUG, has a quite low sensitivity in megaureters, because if the contrast slowly flows back to through this obstructive refluxive orifice and then mixes up with the fluid in the megaureter, you might not see it, even in a very good film. And this is where the contrast enhanced voiding sonography can solve such issues. And then after the second UTI, we did it in this boy, and we saw a clear reflux where you can see the bubbles in the megaureter after a while. So here it's empty and here it's full of bubbles. But as said, it's unclear whether the reflux really influences what we should do about those megaureters, and therefore a VCUG should be done primarily in cases with an index of suspicion that there is any consequence to it. So for example, in boys with bilateral megaureters after febrile UTIs, where you suspect the reflux as an additional risk factor, and depending on the sonographic appearance of the ureter and the upper tract. About the upper tract, when does upper tract dilatation really matter? So if it's not there, it's quite unlikely that there is obstruction. If it's there, there might be a risk of renal function loss, but due to the pressurized tank effect, meaning that the pressure is exerted over the whole system, including the very wide ureter, this is quite unlikely with a megaureter, and much more unlikely than, for example, with a uretropelvic junction obstruction. and there can be an additional secondary uretropelvic junction obstruction in megaureters. Due to the delayed urine clearance in very slow outflow, there might also be an additional risk of stone formation. But what actually is obstruction? According to the current guideline of the European Association of Nuclear Medicine, there is no definition. There's only a definition about what is not obstruction, quick outflow, but not every slow outflow or all those criteria everybody knows, residual activity over 50% after 20 minutes, define obstruction due to those guidelines, and they can be very difficultly applied to megaureters because it of course depends on the region of interest that you draw, whether you see the obstruction. So is it a renal region of interest, or do you incorporate the clearance of tracer from the ureter? And then what are your endpoints? Because of course it takes much longer to clear the whole megaureter than the renal pelvis. So this is a difficult question. If you're sure that it can make a difference, so if there is a vast upper tract dilatation that's getting worse and you really want to see whether the kidney loses function and how the outflow looks, then a Max-Re scan is the way to go. And it should be indicated with scrutiny, not to expose the child to ionic radiation and then draw no consequence. In this example, you can see a quite severe outflow obstruction of the left kidney, and even after more than 2 hours, there is nearly 100% of the original activity, and there is a loss of function. So that is an information that of course helps in looking at further therapeutic options. Other diagnostic measures are really rare to be applied. Magnetic resonance urography only if anatomy cannot be judged in sonography, which is really a very rare event, usually involves anesthesia and should be used with utmost scrutiny. A DMSA scan can be of help if you want to look at progredient renal scarring after recurrent infections and define your therapeutic decision on that. And the cystoscopy in the retrograde pyelography, of course, can exclude an intravesical obstruction in boys. Megaureters are much more common in boys, and also an additional pathology at the uretropelvic junction. So I would like to conclude with again stating that the primary obstructive megaureter is a benign condition with the main risks of febrile UTIs, and therefore diagnostic measures have to be cut to the necessary and reasonable minimum, as always, because they involve ionizing radiation and burden to the children. And after having defined a situation as POM, you have to be very careful to not overdiagnose when there is no beneficial therapeutic consequence. And you should really know about the sensitivity and the pitfalls of your tests, especially in VCUGs and Max-Re scans. This is important. So thank you for listening, and we will take questions at the end of the webinar. And now we'll hand the floor to Nina, who will tell you everything about indications.
So good evening, everyone. I hope you can see my slides as well. So I would like to start or to continue with a brief outlook on the indications of further treatment. First of all, I also have no conflict of interest. And the management of primary obstructive megaureter has changed a lot in the recent decades, as we already heard. And in order to discuss the key points and indications for surgical treatment, I would like, first of all, to give a briefly discussion of the importance of conservative management. Since the early 1990s, several studies has documented a high spontaneous resolution rate of up to 80%. As you can see, for example, in the study of Gimpel et al. From Heidelberg on the left side. And as you can see as well, this takes quite a long time. And during this time, not only the parents, but also we as doctors need some patience. However, various factors must be taken into account. For example, the diameter of the ureter, as it's shown here on the right side from the same study, or for example, the rate of dilatation. Both are good predictive markers. But there are exceptions. Up-to-date conservative management seems to be the best, means it's recommended like first-line therapy if the functional studies reveals and confirm adequate urine drainage and exclude other pathologies, as we already heard from Bernhard. And I would like to give you now, or to discuss with you, the clinical findings that can indicate surgical correction in detail. According to the latest guidelines, indication for surgical intervention are an initially reduced renal function on a renal scan, and a 40%, especially if there is also massive hydronephrosis. And however, the possible presence of congenital renal dysplasia must be taken into account in this context as well. In addition, as well as worsening of the dilatation, we can observe this in sonography, and or a drop in renal function in serial examinations of 5% or more can present an indication. But this also have to be interpreted in the clinical condition as well. Some authors also discuss an altered kidney growth on ultrasound in the absence of reduced renal function in the scans, and this could or might be considered as a sensitive parameter of renal damage as well, and we should have a close eye on this. As we already heard, recurrent and especially breakthrough infections, febrile infections, are a serious complication of primary obstructive megaureters that justifies surgical intervention. And as far as we know, up to date, the rates of UTIs are between 13 and 50% in the first year of life. That has been described in this cohort. And it depends on severity and extent of dilatation. And 1/3 of our patients in these cases require at least one hospitalization due to these febrile urinary tract infections. As I told you that febrile urinary tract infections are one of the most common complications in primary obstructive megaureters, we need to discuss giving low-dose prophylactic antibiotics to prevent urinary tract infections in these patients. And this is why I would like to make a brief decrease on this topic, because most guidelines at the moment recommend, unfortunately with limited evidence and often disagreement, a prophylactic antibiotic therapy within the named period of time. Many authors noted that it seems to be particularly effective in the first 6 months of life, as it reduced the urinary tract infection rate of up to 80%. As it is described, for example, in this study, a systematic review has been published in 2020 with a meta-analysis done by Rona et al. And in the end, they included 16 studies for their meta-analysis and concluded that it should be taken into consideration, at least in the patient who has urinary outflow impairment or a really high grade of urethral and renal dilatation, and especially in the first months of life. But however, its use must be critically discussed when considering the estimated higher rate of febrile urinary tract infection, the likelihood of renal scarring, and the damage and burden, on the other hand, of the antibiotic prophylaxis. Further clinical complications such as associated pain, and as we already heard from Bernhard, stone formation in the dilated urinary tract due to the stasis of the urine makes surgical correction necessary. And in addition, we need to take a preventative approach to the risks that are associated with a lack of resolution over the time in our maybe adolescents or adult patients. And this needs an individual approach with these patients. Take-home messages are, as you heard already from Bernhard as well, conservative management is the primary first-line therapy, and because spontaneous resolution rate is really high, up to 80% in these cases, but there are exceptions. Like the deterioration of the renal function with a significant obstruction, recurrent, and above all, breakthrough infections and clinical symptoms, as we discussed before. And so I would like, therefore, to move on to Raimund Stein's presentation on the various surgical options for primary obstructive megaureter. Thank you very much.
So, hello everybody. I hope you can hear me. Surgical approaches, minimal invasive versus surgical correction. I have no conflict of interest. I think the most important thing, or what we should think about, is what to do in the first year of life if we have a megaureter with a severe dilatation of the urinary system. So I think most of us would agree that wait and see and give these babies a prophylaxis would be appropriate and is a most appropriate treatment option. But if you have problems, urinary tract infections, or really a declining renal function, most of us would do a retrocutaneostomy within the first months of year and later do a reimplant with this ureter. But also, since more than 20 years and now just recently, balloon dilatation and JJ stents became quite popular to use it even in this age. Also, Marty Kiefer brought in a longer time ago to perform a refluxing anastomosis to not to disturb the development of the bladder. And even if they are boys, some of them do not need really a ureter reimplant in this setting. But also you can discuss if an early reimplant after 6 months of age may be an option, but I think most of us would keep it that these patients will be reoperated or reimplant will be performed at least when they are 1 year or older, because due to the possibility of maturation of the bladder and don't disturb the bladder function very early on. Isaac did a review, a systematic review, what is done surgically in patients with megaureters within the last 24 years, and he looked for the publications in these things, and they included 52 studies, and in the end they found or showed that around 1/3 get endourological procedures. And when you look at the publication of last year's, there are 2 systematic reviews just published this and last year. There are a lot of publications from different institutions dealing with the balloon dilatation in these patients and bringing in more and more papers. So what is done in the end? It's you put in a guide wire into the urethral orifice, and then you dilate the abdominal segment with a balloon, and when you're finished, you put in a double G stent in most cases. So the EAU Pediatric Urology Guideline Panel did last year a research and as a systematic review. They screened around 500 papers, just keep this a little bit in mind, the number. And in the end, they found 8 studies qualified for the synthesis, but none of these studies were qualified to do a meta-analysis. So when you look on the other hand about the co-founders and the bias, all of these studies had or have some problems with this. Looking for indication for surgery for endoscopic treatment in this publication. Worsening of hydro in 1 study, symptoms in 6 of the studies, loss of differential renal function in 6, an obstructive curve in a MAX3, whatever this means, in 2. And when you look at the success rate, and most publications had a higher success rate, 35 to 97% success rates were reported. But what is success in these patients? And for definition in these papers, 6 of the 8 studies used a decrease of hydro as a success in these patients. So, but when you saw the curves Nina showed, you have a decreasing dilatation in most of the ureters. Improved or even stable drainage of the MAX3 was in 3 studies. So if you have a bad drainage and it stays the same, it's a success. I don't know. No obstructive curve on the MAX3 in 1, which is quite a good definition. Absence of symptoms, only 1. You saw indication for surgery was 6 in 6 studies, but the absence of symptoms later on was a success in only 1 of these studies. Absence of VOR, absence of UTI in 2 of the 8 studies. No further surgery in 1, and 2 studies did not really report what they used as a definition for success. Complications with these treatments are quite common, and you see it's around 20 to 90% even in 1 study. 2 studies did not report really the numbers of complications, and usually it's more stent migration, intolerance to the double G, which is very well known, UTIs, sometimes with urosepsis, hematuria, I think this is normal, pain, and even some stone formation. So the salvage reimplantation was performed in 1 study only with 3%, but usually between 10 and 20%. But on the other hand, you have to keep in mind that the spontaneous resolution rate in a primary obstructive megaureter is around 80%, and 20% will go to surgery only. So in the end, the AUA Pediatric Guideline Panel, the paper is still in press, they concluded that it may be an alternative for ureteral reimplantation with a modest success rate in the long term. And it could be performed at any age with equal success and complication rate. And then you have also at the same year a systematic review published by other guys, including 1,000 papers they scanned, which is doubled of the papers from the EAU. They included 13 studies instead of 8. But in the end, they came up with the same things. In America, there are always incomplete data. There are no proper data for meta-analysis in all these published studies. It seems to be that high-pressure balloon dilatation is at least safe, but identifying those patients who will really benefit from high-pressure balloon dilatation remains challenging. So on the other hand, when you see this long segment and this dilated ureter, ureteroneocystostomy using one of these techniques may be a definitive solution. And when you look at the cone technique, where you just pull the ureters into the bladder, when you have your obstructive megaureters, you have to do a tailoring or application of the ureter to get a nice tunnel and to get no reflux later on. The same you can do using the Politano-Ledbetter technique, which is a little bit more complicated. Or that's something which we like much more is using the Psoas-Sich technique, where you really can resect a part of the pathological ureter, and then the rate of tapering and is much lesser than when you have these other techniques. And for tailoring, you can cut it like with this clamp, you can implicate it, you can use Alice clamps. In the end, it depends on your decision what you feel comfortable with. So in the end, for the operative treatment, most primary obstructive non-refluxing megaureters really do not require any surgical correction. The indication for intervention in the first year of life is quite rare and should be taken care. Temporary diversion means if you have a septic child, with a severe urosepsis and all these things. This happens quite rare, and as we put most of these kids today under antibiotic prophylaxis. Oops, no, sorry. No, an endoscopic intervention may be today an option, but the question is for whom? Who will really benefit from this technique and why? And in the end, ureteroneal cystostomy is definitely a solution, a definitive solution. But something I think everybody has to keep in mind, and I'm happy that Anna will tell us something about the follow-up. How long should we follow up the patients and how and these things? This was a guy, 20 years old. He was followed in Mainz a long time ago with a conservative treatment because he had stable renal function, no really worsening of dilatation. And in the end, at the year of 20 years, he had a stone, he got septic, and then we had to do a reimplant and resection of these megaureters. And when you see this, we have to think about if we should really keep on conservative, if we have still a good dilated ureter. The question is, how long should we keep conservative and what can we accept in the long run? So I'm happy to pass the task to Anna, how we should follow these kids.
So, as in many other pediatric urological conditions, there's a need for follow-up in primary obstructive megaureters. But the question is, for which kind of megaureters exactly, how long, and by which diagnostic method? Today, there's no doubt that aftercare and follow-up, and it was already stated, is necessary for all primary obstructive megaureters, regardless of being managed conservatively or after intervention or surgical reconstruction. However, till now, we do not have prospective data. Looking at the available guidelines, you might find the British guidelines, which state that there's no consensus about the duration of follow-up. For conservatively managed megaureters, it's recommended to follow them up long-term, as symptoms could occur later in childhood and even in adulthood, and you already have seen such a case. So how long is a long follow-up? You can see here that most megaureters are followed into adulthood. The longest follow-up here is median 13.4 years, was reported from Philadelphia in 10 patients with 16 megaureters. The largest study here on the bottom has a shorter follow-up, but it's a recent population after balloon dilatation, and we can assume that the follow-up will be continued. Firstly, we must define what resolution of an obstructive megaureter means. The lack of clinical symptoms is, of course, the straightforward definition, meaning no pain, no colic, no UTI, no stones. Some declare resolution when the megaureter diameter is less than 6 millimeters. Others consider it when there is a residual hydroureteral nephrosis less than grade 2, according to the Society of Fetal Urology, and a retrovesical diameter less than 7 millimeters. Having a look at resolution rates in literature, we learn from the study from Israel that about 30% of children allocated primary for conservative management undergo surgery before the age of 2 years. This means, on the other hand, that the vast majority, and you already heard this, does not require surgery. If improvement of the megaureter was seen in that series within the first 4 years of life, it was unlikely that further deterioration occurred during the long-term follow-up, at least for the next 12 years. So most authors recommend ultrasound until puberty on an annual basis in all megaureters and further imaging on an individual basis in cases of sonographic worsening of the hydroureteral nephrosis or development of symptoms. However, what happens to those megaureters which do not resolve within the expected time frame? On the left, you see the resolved megaureters, the majority. On the right, you can see the ones after operation, but in the middle, these are the resolved ones. In this study, about 10% did not resolve during the follow-up of 4 years, and they still show either a considerable ureter diameter or a significant hydronephrosis of grade 3 or more. The biggest fear, however, is the silent loss of renal function during follow-up. Luckily, this is rarely seen. The unanswered question, however, is whether these few cases, published cases of course, justify a more invasive follow-up, including functional diagnostics in all patients. So it is worthwhile to take a look at the adult population. Surely this is a historic cohort presenting with a late diagnosis of persisting megaureter. These patients were in their 3rd or 4th decade of life. The majority was symptomatic, most were male, and the megaureter is mostly affecting only one side. Only 4% did not have symptoms at all. In these adult patients with megaureter, 12% had CKD, and this was mostly in bilateral megaureters. 7% of these patients showed no improvement of renal function after surgery. In addition, the colleagues from Philadelphia suggested that females, these are the minority, but with persisting megaureter, should inform their obstetricians when they are pregnant. Regarding follow-up, with the lack of a definitive endpoint and in the light of these findings of adult patients, John Park recommended to continue follow-up even in cases with resolution by periodic ultrasound, especially in those with former severe hydronephrosis or residual dilatation. After intervention or surgery, regardless of methods, all patients with megaureter should be followed once a year until resolution of any pathology. Take a look at morphology and peristalsis of the ureter, compare dilatation to baseline, and do not forget bladder function, monitored by residual urine and bladder wall thickness. Renal scans need to be compared to the baseline findings. If febrile UTIs occur, do not forget comorbidities such as constipation and treat them. Urodynamics, VCUG, and the contrast-enhanced voiding urosonography might be helpful. A cystoscopy might rule out an earlier overlooked intravesical obstruction. So to summarize, regarding follow-up, annual sonography is recommended until resolution of any pathology and maybe beyond. Further imaging must be planned on an individual basis in cases of sonographic worsening of hydroureter nephrosis or development of symptoms. All megaureters after surgery or balloon dilatation should be monitored long-term, whatever this means. We are at the beginning, also for bladder function and especially in cases of UTI symptoms. Thank you very much, and we are happy to take your questions.
Okay, do everybody want to put their cameras on? That'd be great.
Here we go.
So just a reminder for everybody, send your questions through now. We've got around 15 minutes. I've sent one through already on the chat to you all, so I think it came through during Raimund's presentation, but whoever wants to answer, please do. Then I'll give some more messages later. So. Thank you.
I just make a comment on one question. Could you recommend on the risk of VOR after balloon dilatation? There's a risk, I think, around 10 to 30%, depending on the study and how you look after this. But even if you have a VOR after balloon dilatation, I think it matters only if you have UTIs. And if you have UTIs, then you have to take care of this. So, and that's the same, I think, when you do a reimplant. you only would do a look for reflux if you have definitely UTI or fibral UTIs, then you will treat the reflux. Otherwise, you won't look for that.
The question is, what's the reason? What's the presumed etiopathogenesis of the primary obstructive megaureter? That's a very interesting one. I think the most honest answer is we don't really know. It certainly is some sort of a pathology at the uretrovesical junction that has probably to do something with the remodeling of muscle fibers and connective tissue. There are some papers reporting on matrix metalloproteinases being involved in that, and there is a theory also from an embryological side that it has to do with the outsprouting of the ureteric bud, so a very early event, and might be the result of something that we might also see in reflux maturation, so that the connective tissue around the ureter is changing. But I think we really don't know, and what I'm sure about is there are no known genetic pathology to look up, and there is no therapeutic consequence of any etiopathogenetic theory other than it can resolve.
I think I have to answer the question. In case of JJ stent insertion, does it have to reach the renal pelvis or only have to transverse through the obstruction? I think everybody would be happy if the double G is in the renal pelvis, but in the end, what you want to treat is, or what you want to dilate or overcome is the narrow segment. So I think at least it should be there, but sometimes also it happens because due to the severe dilatation that the double G stent went up completely in the ureter, and then you have really a problem with this. So there's also some risk and one of the complications you had in all these studies.
So I could comment on the question how a bilateral obstructive megaureter shall be managed. So first of all, as Bernhard told us, you have to, in boys, exclude in subvesical obstruction like ureteral valves. This is very important. And as I told you, the first line therapy should be a conservative therapy. So wait and see. And in case of massive obstruction, we have to do the diagnostic steps Bernhard taught us, and to see whether there is significant obstruction with renal impairment, or in case of febrile infection or severe febrile infection, which can't be handled conservatively, then we have to discuss surgical options. The problem is that in the first year of life, as we heard from Raimund, we want to avoid reimplantation due to the bladder problems which can be caused by early reimplantation. So we have to see whether both sides are obstructive, and this is quite complex and tricky because we have the options for example, ureter cutaneostomies, which is something we prefer doing it. But in these cases, when we have to do it bilaterally, then we exclude the bladder from cycling, and this is quite bad for the bladder. So we have to see whether this is really, really necessary and have to find options to avoid it. There might be an option for stenting as well, but this is not a prolonged option or approach. So these are quite tough cases to manage.
You got
There's one question about. There's one question: how long do you keep the JJ stent after balloon dilatation? In the studies, it's around a couple of weeks, 3 to 4 weeks, 6 weeks usually, but some use it even for 3 to 6 months. So anyhow, this is just quite a long time, and some change it even. in between. And the other question is there any role of internal ureter cystostomy, thinking about you can get the risk of reflux? Yes, it is a refluxing anastomosis because you don't want to disturb too much the bladder, but when you think also when you put in a JJ stand or you do balloon dilatation, you have also reflux. And reflux makes only problems if you have UTIs. So sure, this is a risk. And this is definitely also not our preferred option, but I think it's also one option you have to think about and discuss it.
So we normally use deep, sober, so a loop ureterocutaneostomy. Yeah. So this is preferable to for the re-implant as well.
There's one question about purulocutaneostomies, and as I was originally trained in Mainz and Professor Bernhard did use this quite a lot, of purulocutaneostomy, and quite know these things. The positive thing about a purulocutaneostomy is that you have a direct drainage of the kidney. The negative effect is that you need to close it, and later on you can do a reimplant and correct the pathology down below. So I think there is no good indication today for a purulocutaneostomy at the moment. And so we use in Mannheim usually, and I think Anna and Bernhard, I don't know, I think you too, we use a low ureterocutaneostomy as shown in the pictures. And then when the child wants to get toilet trained or after the first or second year of life, we would do a reimplant. Maybe you can comment on this too, Anna, because I think you know the old days with the purulocutaneostomies and these things.
Yeah, you already mentioned the advantages of this technique. When you have it in the lower abdomen, it's very easy to take care for. The parents accept it very good. They need a short period of training. Then it's not visible. It's in the diapers, and you do not need like a bag or whatever to have the child safe and accessible. Access to the urinary tract is quite easy. If there is a doubt about urinary tract infections, then you can catheterize it, and I think it's a good solution for the children. And usually we when you reimplant, you can use the same incision, so it's cosmetically very nice, and you have a direct access to the bladder from that point. So it's a very good idea in our hands.
So we're not doing terminal ureterostomies, we're doing loops, because there you have some flow into the bladder as well.
Maybe Bernhard, you can comment on the last question, because I'm a little bit biased.
Well, of course, I have to disclose that I'm not convinced about balloon dilatation myself, and I really cannot, as Raimund said before, I cannot think of any wise criteria to select somebody for balloon dilatation, honestly, because if there is no need to do something, I would do nothing. And if there is a need to do something, I would strive for a definitive solution. And then in my world, in megaureters at least, there is really no place for balloon dilatation at the moment. And therefore, I cannot answer the question otherwise than looking at the literature, as we did together with Raimund, and they say, well, if there's an obstructive outflow from a Mach3 scan, if there are infections, but to this end, there is no data whether the balloon dilatation really helps. And to the other side, there is no really convincing data, at least from my point of view, about the potential risks of balloon dilatations. And therefore, for me personally, it's an intervention without indication and without really well-defined risks in the medium to long term. And that's why I don't use it. probably those with a little bit of megaureter where you want to do something but not really need to. But then the question is whether you really would like to do surgery in such patients or not. Modality. Is there any other diagnostic modality that shows us the length of an aperistaltic segment, MRI or others? So I'm sure that the aperistaltic segment length cannot be shown by MRI, and I can't think of another modality other than a retrograde pyelography, where you might, with a lot of skill, get an idea how far it is from the cystoscope tip to the white part of the ureter, but then I believe it doesn't make a difference in terms of how well a megaureter might mature or not. I'm sure this is about function and peristalsis and changes in the extracellular matrix of ureteric wall cells, and not the length doesn't matter in that respect.
It may matter if you think about balloon dilatation, which you don't do. We don't do it either, but I think there may be a role if you have a critical ill child and all these things, and don't want to have, not ill due to the megaureter, but otherwise to have a quick solution, and you have a very, very short segment and not a severe obstruction. This maybe could be an indication. And on the other hand, when you think about definitive treatment, I think the length of the aperistaltic segment doesn't matter anyhow. You will see it, sometimes you're surprised that they're very small, and sometimes they have a very long, as shown there. But in the end, for the definitive treatment, I think it doesn't really matter.
Okay, thank you all. That's all the questions for now. So if anyone has any else they want to put in now, please do. Just while people are thinking about that, just a reminder to everybody that all those who have attended today will get a survey after the webinar finishes in about an hour's time. We'd be really grateful if you could complete that. Those who complete it within a 2-week period will also then receive an accreditation certificate for CME credits. Reminder again that we'll send out links to recording for this tomorrow for our GoToWebinar and YouTube channels. Please look at our website for future sessions. We'll be running them up until kind of mid-March, then we'll have a break until April, but there's quite a few sessions listed on the website, and we'll put the links on there for registration as soon as we have them, and they'll also be sent out to all people who have registered previously as well. So there's quite a few people saying thank you to the presenter, so I will send all those on to you later for your information. So I'll say thank you to everybody for attending, and thank you most of all to all our presenters today. It's been really interesting and yeah, perfectly timed as well. We're finishing dead on 7 o'clock, so thank you. If there is anything else you all want to say, please do, then we'll finish the webinar. Thank you.
Okay, thank you for listening. Have a good evening. Goodbye.